everyone. I'm excited to get started on another great Department of Medicine Grand Rounds. I'm Allison Bond, the Medical Director of Grand Rounds. And just to start, just want to acknowledge that our hearts are heavy and our hearts are with our colleagues at the General this week in particular. And I'm excited to introduce our fantastic speaker, who's Dr. Thiara. So she's an associate professor of medicine in DGIM and the medical director of the UCSF Weight Management Clinic and primary care at 1600 Divisadero. She's also the program director of the UCSF Obesity Medicine Fellowship. And very cool, she runs a culinary medicine program at UCSF. She received her bachelor's degree in political science from Yale, MD from Vanderbilt, and then she's been here at UCSF for IM residency and fellowship. Take it away.
It's a pleasure to be here today to talk to you all about the modern paradigm and how we think about treating obesity and the comorbidities associated with excess body weight. So here are my disclosures. In terms of objectives, by the end of this session, I hope you can all describe the treatment paradigm for obesity, know the current FDA-approved medications for long-term use for obesity management, basic understanding and explanation of the pharmacology of GLP backbone drugs, and most importantly, really understand the various roles these medications can play in both treating obesity and the comorbidities associated with excess body weight. So before we get into the data and talking about how we treat obesity, I think it's always important to step back and think about what is our goal in treating obesity. As medical professionals, our goal is to help our patients live longer, healthier lives. And when it comes to obesity treatment, it's the same. We want our patients to live longer, healthier, more robust lives. We're trying to focus on health. We're not trying to promote this idea that everyone needs to look the same or be a certain size in order to be healthful. You should not assume that someone who lives in a bigger body is inherently unhealthy or not able to move or exercise. It's just simply not the case. It's also really key to understand that even modest amount of weight loss can improve health. We know that above 5% body weight loss, we start to see clinical improvements in comorbidities. So at that 5 to 10% body weight loss, we can see prevention of diabetes in people with prediabetes. We can see improvements in MASH. At that 10 to 15%, we start to see reduction in CVD, OSA, and above 15% body weight loss is when we actually can see remission of certain disease states like diabetes. We don't need to fixate on BMI targets. It's really these percentages of weight loss that matter for someone's long-term health. It's very daunting for a patient and also for us as providers if our expectation is to have a patient who has a BMI of 60 and get them to a BMI of 25 in order to improve their lifespan. It's just setting someone up with these high expectations that are really, really challenging to meet. And more importantly, the data just suggests that that's not the case. With these more modest amounts of weight loss based on percentages, we can really help someone live a longer, more robust life. The other key is that as we think about treating obesity, we should think about it as any other chronic disease management. This is going to require a lifelong treatment approach. There will be ups and downs, and we as providers should be there for patients during these times. And we also should have realistic expectations that it's not a linear improvement in someone's weight. There will be fluctuations just like other disease states, and we can employ different treatment measures now that we have so many in our toolkit. So how do we actually think about treating obesity? We used to talk about it like a pyramid. As BMI escalates and the number and severity of comorbidities associated with excess weight also increased, our interventions could also increase with intensity. But as we've developed more effective anti-obesity medications and we've understood more of the role of these various treatments, we think about obesity treatment more as a pillar of foundations. There's 3 key pillars in how we can provide comprehensive care to our patients: lifestyle change, pharmacotherapy, and procedures like bariatric surgery or endoscopic intervention. So the care paradigm really isn't one or the other. It's more of a yes and approach. How can we use all of these pillars with our patients and their preferences in mind to have a chronic, complex disease management care for our patients? One question I get a lot from patients, providers, anyone in my life who knows what I do for my job is, does lifestyle change really matter? We have these incredibly effective medications. Why does any of the rest of it count? Well, simply put, a medication isn't going to teach someone how to eat better or move their body in health promoting ways. So lifestyle change is still a key pillar to our treatment paradigm. Lifestyle change is composed of exercise, nutrition, and behavioral therapy. When it comes to nutrition, our goal is to promote this healthful, nourishing intake of food. We want to make sure our patients who are on medications, had surgery, or focusing on lifestyle change are getting adequate micronutrient and macronutrient composition. Protein is all the rage right now. Some of you may have had a protein drink from Starbucks today, and protein does matter. You know, if you're actively losing weight, it increases satiety. If you're undergoing any intervention for weight loss, it can help promote positive body composition changes by keeping up the lean muscle mass. But the reality is that the data in America suggests almost all adults are intaking adequate protein, and where we fall short is around fruit and vegetable intake. So while we want to counsel around around protein, we also want to counsel around high fiber, minimally processed foods, things you can see in nature and imagine that on your plate directly. Nutrition matters to help people lose weight, but it also matters because it can mitigate a lot of the side effects associated with the medications as well as bariatric surgery, and we'll unpack some of that in a bit. The next key component of lifestyle change is activity. The CDC and the American College of Sports Medicine recommend that adults over the age of 18 engage in 150 minutes per week of moderate aerobic activity per week, plus strength training twice a week. And that guideline is to maintain your adult weight. It's not necessarily for weight loss. But how do we stack up? So not surprisingly, very few Americans are reaching these activity guidelines. About 28% of males and 20% of adult females in the US are reaching this. But what you can see that's even more concerning is that with age, fewer and fewer people are meeting those activity guidelines. Why does that matter? Well, for everybody, there is age-related sarcopenia. So if we're not moving our bodies appropriately, our body composition is changing in a deleterious way. The other fact of the matter is we know who the prime users of these GLP medications are. It's women in that blue and light green range. So the 35 to 64-year-old adult woman is most likely to be using this drug, with 1 in 5 women between the ages of 50 to 64 saying they've used a GLP at least once in the last 5 years. This age group is steadily declining in their activity rates, so it's up to us to help engage them in discussing more about activity. We also know that engaging in that strength training twice a week, meaningful strength training, can preserve lean mass with weight loss. That is robust data from the bariatric surgery population, so it's not new. We know that if someone's doing 2 to 3 times a week of engaging all of their muscles, they're going to have a better body composition analysis at the end of their weight loss process. And then the last component of lifestyle modification is behavioral therapy. We want to make sure we're helping patients retrain the response to cues that lead them to making certain lifestyle decisions that can be negative when it comes to chronic disease management. So as we think about the rest of this talk, please remember that this lifestyle change pillar is still incredibly important as we're caring for our patients who have excess body weight. So now let's move on to the rest of the talk and why I'm sure many of you are here today, which is to discuss pharmacotherapy options for obesity treatment. There are currently 6 FDA-approved medications for long-term use in obesity management, and we go in order of how they have come about in approval. So the first we have is orlistat, a lipase inhibitor. It is a pill by mouth. It is not clinically effective at all, only about 3% body weight loss. It has really negative side effects, which is flatulence and other lower GI symptoms. So we don't really use this much in our practice unless we're forced to by insurance before we're able to escalate to other treatment options. The next medication we have is Contrave, which is an oral pill by mouth that's a combination of bupropion and naltrexone. And with this medication, we see about 5 to 8% body weight loss at 1 year, with maintenance of about 3 to 5% at 2 years. The third medication is Saxenda, which is a daily injectable GLP medication that came on market around 2013. And this medication has about 5 to 10% body weight loss at year 1, with maintenance of 6% at year 2. Next, we have Qsymia, which came about around 2014, an oral pill by mouth that's a combination of topiramate and phentermine. And with this medication, you see about 9 to 14% body weight loss with maintenance of 10% at 2 years. And then we get to 5 and 6, which are the more modern medications we have. We have Wegovy, which is semaglutide 2.4 milligrams, which is a weekly injectable, 12.5% body weight loss at 1 year with maintenance of that at 2 years. And then we have Zepbound, which is tirzepatide, a novel dual GLP-GIP medication that's a weekly injectable with 17.8% weight loss at 1 year, and more profoundly, an increase of weight loss at 88 weeks. So when you look at this list, you might say, hey, number 4 and number 5 aren't really that different. Why have I never heard of Qsymia before? Well, what's more important is what you see with that maintenance. So if we want our patients to have reduction in morbidity and mortality, they need to be able to keep that weight off so that their comorbidity status improves in the long run. And with things like Qsymia and the older medications, we didn't have maintenance of that weight loss. So there weren't any long-term comorbidity data even studied. The newer generation of medications like Wegovy, Zepbound, and everything to come has way more promise and success showing that long-term weight loss and potentially even more delayed plateaus, meaning weight loss for longer than that 1 year mark. So let's get into it. We'll step back a little bit for the people who've been in the clinic experience for a while and open some textbooks and think a little bit about how these medications actually work. So we as humans evolved for our hunger and satiety signals to be regulated in the hypothalamus by this complex set of feedback loops between gut hormones and the brain. So the gut would send signals of hunger or satiety to the brain based on food that the body had ingested and its energy balance. So there's one main pro-hunger or orexigenic hormone called ghrelin that's produced by the gastric fundus. And then there's many anorexigenic or satiety signaling hormones from the gut that are secreted from all over. So there's things like leptin, which is from fat cells. There is GLP, which we're all intimately familiar with now, PYY, amylin, CCK, and insulin also has a role in satiety. And what those hormones do is they go and they act in the hypothalamus to say, hey, you have had enough to eat, you feel full, or you really need to be eating more, so I'm going to make your brain feel hungry. That's how we evolved. But we all know that we now eat for reasons that have nothing to do with hunger, which is why the historic medications didn't really work in the long run. They were mostly acting centrally. They were balancing that hypothalamic set point and that hypothalamic satiety or hunger pathway to try and convince people that hunger noise is gone. But that fades over time. And if there's not a peripheral action that's effective, the weight maintenance isn't going to be there. So how do GLP receptor agonists work? GLP receptors work on the stomach to decrease gastric emptying, so food sits in people's stomach longer. They act via POMC-CART in the hypothalamus to promote satiety. They act via the pancreas to increase insulin secretion and via the liver to improve insulin sensitivity. And those last two bits are why these medications also work for diabetes. And then GIP has this added effect of increasing lipolysis and fatty acid synthesis. One key fact is that the dual agonist is much more weakly agonizing of the GLP receptor than the monoagonist. So while they're similar, they're all GLP-1 receptor backbone medications, the dual and the monoagonists actually are different in terms of how agonizing they are to the GLP receptor, which is why you see marginally different side effect profiles. So a patient who can't tolerate a monoagonist may be able to tolerate the dual agonist because of that difference in GLP receptor agonism. All right, so bringing it back to how we would talk to patients about this medication. What are the main side effects? Well, they correlate directly with that mechanism of action. Almost everybody has nausea when they initiate this medication. About 85% of study participants in the RCTs showed that. But the importance is that signal really should decline very precipitously before you decide to up titrate. Vomiting happens, but it's not normal. It's not health promoting. So if your patient is vomiting and it's not getting better, they can't tolerate this medication, it's probably not a long-term solution for them. We do know that nutrition counseling, reducing high-fat meals, big portion sizes can reduce a lot of those upper GI side effects. Then on the other end, we have things like diarrhea and constipation, seen a little bit more with the dual agonist than the monoagonist. And clinically, we see a lot more improvement in these symptoms for people who add on a fiber supplement. So even someone who's having a super high fiber diet, if they're having those lower GI symptoms, I would recommend adding a daily fiber supplement and really encouraging increased water intake for those who have constipation. Fat needs water to hydrolyze. So as patients are losing fat, they actually need to be drinking more water than they had been. So it's a key aspect to not forget in the counseling. Other symptoms are things like headache, fatigue, usually more around low PO intake. The rare but serious side effects in the RCTs were things like pancreatitis and cholecystitis, seen in less than 1% of the study population. And I note suicidal ideation here. It was not seen in the RCTs, but in some of the post-reporting to the FDA, patients had been noting it. Since then, retrospective studies done both on semaglutide and tirzepatide have not shown any consistent increase in SI in patients on these medications, but it's still important to just have that conversation and be aware of that as a provider. There are two absolute contraindications to use for these classes of medications. One is a personal or family history of medullary thyroid cancer or MEN type 2. This has given these classes of medications a black box warning. But again, the asterisk here is that was seen in rat studies, and the rat thyroid is not a good human thyroid surrogate. So it's not something we're seeing play out clinically, but we're still quite rigorous in screening and making sure patients don't have that history before initiating the drug. And then the next absolute contraindication is pregnancy. These medications are not teratogens the way something like Qsymia would be, but they do increase the risk of fetal loss through placental disruption. The other side of the coin is we have seen a lot of anecdotal accidental pregnancies because fertility rates do increase as weight goes down. So while we have seen successful pregnancies for anyone who's trying to get pregnant with high rates of fetal loss for unknown reasons, you don't want to add something else to a patient's plate of concerns if they're actively trying to conceive. In terms of results, we talked about those 1-year data. But what's really important to know is that for semaglutide 2.4, over a third of participants in the RCT had over 20% body weight loss. And for tirzepatide 15 milligrams, over a third of patients had greater than or equal to 25% body weight loss, which is the lower end of something like a sleeve gastrectomy. And how do you use these medications? They are weekly injectables, and you technically can get to effective dose in 5 months. So you increase dose monthly until you reach effective dose. That being said, if someone is having a lot of side effects or they're responding quite robustly to lower doses, you don't have to follow that up titration plan. You should use your clinical judgment. Again, another asterisk is some insurances will not actually allow you to sustain someone on a titration dose. So for tirzepatide, you would have to maintain them on 5, 10, or 15, but some insurances don't care. So it's a little bit of you have to try and see what the insurance will cover. So stepping back a little bit to this idea of a third of participants responding more than others, we don't know who's not going to respond and who's going to respond to these meds. There's a lot left to be done in that space, but there has been a lot of subgroup analyses of the STEP trials, the SURMOUNT trials, as well as prospective race and ethnicity studies done in Asian countries like China, Japan, South Korea, and Thailand. And what we know from those studies is there's no obvious racial or ethnic group that is responding more than these averages, and there's no group that's responding less. So there's not a clear racial ethnic driver for response. But what we do know based on sex-based group sub-analyses is that females respond to these medications, specifically tirzepatide, more robustly than males. So this study was published in the spring, and it was looking at all of the SURMOUNT trials. So the tirzepatide for weight loss studies are all labeled SURMOUNT, and these are the first 4 RCTs. And what you can see is that for every RCT, the female patients are responding more greatly than the male patients, with SURMOUNT 3 having the biggest delta. SURMOUNT 3 had a 12-week ILI, run-in phase, which meant patients had to lose weight through lifestyle intervention before being randomized to drug or placebo. And what you can see is that the placebo difference for the female patients in SURMOUNT-3 is a weight loss of around 27.5%, whereas for the men, it's closer to 18.8%. So that's a quite profound difference. SURMOUNT-4 was a discontinuation study where patients were taken off the medication, and sort of on the flip end, the female patients lost more, but they also gained more when they came off the drug. So extremes in both directions. SURMOUNT-1 is also important to know because this is looking at the different doses. So 5 milligrams is that light line, 10 is the medium blue, and 15 is the dark. And what you can see is that the average weight loss for female patients on the lowest dose was 17.5% body weight loss. So why do I bring this up? Primary care is hard. These meds will live in primary care, but medications like tirzepatide have really robust responses in certain patients. We know our female patients are more likely to have a lot of weight loss, so you need to be checking in on them before you decide to dose up titrate. You don't want to overshoot the mark and cause new problems because someone lost too much weight too quickly. The next question that I get asked a lot, and I'm sure many of you wonder, is what's actually happening to the body composition when people are losing weight? We know that with any form of weight loss, whether it's lifestyle intervention, surgery, or medication, people are going to lose adiposity, but they're also going to lose fat-free mass. And it's about 25%. That's pretty standard. When we look at the drugs, we see that that's pretty consistent for tirzepatide. About 25% of the weight loss is fat-free mass. But for something like semaglutide, it's a little higher at 40%. Skeletal muscle is about half of that. So the rest of the fat-free mass is things like water and other things. And then with retatrutide, which is a triple agonist that's currently in phase 3, we're seeing about a third of that weight loss is fat-free mass. Now, does this lean mass actually impact our patients and their muscle function? Well, in short, we don't really know. The studies are not there yet to tell us. But if you think about obesity and adiposity and muscle tissue, we don't think it's going to be that significant for actual muscle function. And why? Well, first, individuals with obesity have higher amounts of muscle mass than lean individuals. So as they're losing weight, they may be losing muscle, but it might be close to what someone who's lean has at baseline, so still having good function. The other bit is the muscle mass to adiposity ratio improves because the larger percentage of weight loss is adiposity. And so that cardiometabolic profile of body composition is improving. The other thing that we can extrapolate from is the STEP 9 trial. And this is a study looking at semaglutide in those with knee OA, and we'll unpack it in a little bit, but it showed improvements in function. So people lost weight, presumably the same amount of lean mass as these other studies, and their functional improvement went up. We also have the SEMA-LEAN trial, which was in RCT looking at body composition changes and hand grip strength in people on semaglutide. It showed increase in hand grip strength, but the patients didn't lose as much lean muscle mass as we see on average, so we can't extrapolate too much from that study. And then the last bit is that we have a reduction in intramuscular adipose tissue. And why does that matter? Because intramuscular adipose tissue increases inflammation, which increases the risk of metabolic disease, but it also impairs muscle function. So that adiposity in the muscle tissue is disrupting the healing and regeneration, so blunting the effects of strength training. And then it's also disrupting the orientation of those muscle fibers. So it's decreasing the force that the muscle can generate. The last bit is that IMAT is decreasing mobility in that net decrease in strength. So while we may be losing some lean mass with these interventions, because we're also losing that intramuscular adiposity, the muscle that remain may actually function better than it had while that IMAT was there. But these are all hypothetical. We don't know that yet. And so what are we doing here locally? We're very lucky to have Dr. Christine Gudziag in the physical therapy department. And she is doing a pilot study, RO1, with our team in weight management, looking at just this in older women using GLP medications. So she'll be getting body composition studies through DEXA scan as well as CT of muscle to better understand that muscle composition. And then we'll be doing a battery of physical tests, including hand grip strength and walking tests. So more to come there. So now that we've unpacked the efficacy of these medications in that first active phase, the next question always is, I've lost the weight, or my patient's lost the weight. What now? Do they have to stay on the drug? And the answer is probably not surprisingly that yes, you do need to stay on these medications. So with semaglutide 2.4 milligrams, we had the step 1 extension trial that took individuals who were on medication, and at 68 weeks, they were stopped. And what you can see is that they regained 11.6% of that body weight that they had lost. So they had regained 2/3 of what they had lost. And what's even more important is that what they retained was only around 6%. So if you remember the beginning of this talk, that's not going to lead to those long-term reduction in morbidity and mortality associated with excess body weight. So we're losing a lot of that long-term health benefit when someone regained their body weight. With tirzepatide, we had the SURMOUNT-4 trial where everyone was put on medication, and at 36 weeks, half went to placebo and the other half continued. And you can see that with that darker colored line, those who remained on drug continued to lose weight, and those who were switched to placebo regained, again, around 2/3 of their body weight and landed at a place that wasn't that clinically meaningful. The why, so, chronic disease management, just like any other intervention, if you take it away, the problem will probably return. But to sort of think about it in terms of the hormonal changes, we also know that with weight loss, those orexigenic hunger hormones go up. So as people lose weight, their ghrelin increases. We know this pretty profoundly from bariatric surgery as well as dietary studies. And the satiety or anorexigenic hormones go down. So leptin is secreted by adipose tissues. So as someone loses weight, their adipose reserves are going down. So they're making less leptin. They're also making less PYY, amylin, CCK, and endogenous GLP. The other thing that we're learning more about are actually the central responses. So individuals with obesity and fMRI studies have lower dopamine responses to food cues than lean individuals. What's sort of a downer, to put it simply, is that in small studies that have looked at people on GLPs who've lost weight, their dopamine sensitivity and response has not improved to be equal to that of a lean individual. So we don't think that centrally those dopamine changes are happening so that those satiety feeling happens with weight loss. So if you remove the medication, all of those central processes that are decreasing hunger are gone, and the patient's endogenous dopamine response hasn't improved, you're setting people up to have that increased feeling of hunger again and less of a response to food cues the way they had prior to being on the medication. All right, so now that we know about the medications and that we need to be on them for the long run, let's start to actually unpack the data looking at the use of these medications in individuals with obesity and other comorbidities. The SELECT trial may be familiar to some of you, especially any cardiologists in the room. This was a large-scale RCT looking at the use of semaglutide on individuals with known cardiovascular disease and overweight or obesity. It was a very large-scale trial with over 17,000 participants. Half received drug, half were on placebo. Diabetes was an exclusion factor, and it was a long study with about 4-year follow-up. Most studies for obesity interventions are largely female because we all know that society disproportionately tells women that they need to look a certain way to be valued. But because this required that baseline ASCVD, this study skewed to be more male and slightly older with a starting age of 61. It's key to know that the ASCVD criteria was strictly defined as MI, stroke, and PAD because the FDA has really high fidelity to study design when it comes to obesity trials. So the inclusion criteria for ASCVD, again, was MI, stroke, and PAD, not our broader understanding as internists of what ASCVD is. And the outcomes are quite profound. So box A here on the upper left was the primary cardiovascular composite endpoint. And what you can see is about a 20% risk reduction in that primary composite endpoint at the 48 weeks. This is the first medical intervention for weight loss that's showed a reduction in morbidity and mortality. So it's incredibly seminal to our field. The thing that they don't put in the paper, but that's in the supplement, is that the weight loss at that 4-year time mark was only around 8 to 8.5%. So these patients had this profound reduction in MACE, similar to like metformin in a diabetic, with maintenance of only around 8 to 9% body weight loss. Box B is death from cardiovascular cause. And what you can see is that confidence interval just crosses 1 at 1.01, so it's not considered statistically significant. But we do see statistically significant reduction in heart failure composite endpoint, as well as death from any cause. So it's these results from the SELECT trial that has given this medication FDA approval in individuals with a BMI of 27 or over with known ASCVD, that's defined as MI stroke or PAD. And this ancillary FDA approval expands coverage to people with Medicare. In terms of tirzepatide, SURMOUNT-MMO is still enrolling with study completion date set to be in 2027. So we have a bit more time until we get the corollary data for Zepbound. The next big trial in the medical obesity space is SURMOUNT-OSA. And this study is a phase 3 trial looking at the use of tirzepatide in individuals with moderate to severe OSA and a BMI greater than or equal to 30. Moderate to severe OSA defined as an AHI greater than or equal to 15. Diabetes, again, was an exclusion factor, as well as central sleep apnea or planned surgery for sleep apnea. This study was about 1 year, 235 participants with 2 trial groups, those on PAP and those not on PAP. And again, because of that OSA requirement, more males than most weight loss studies, and the starting age was a little older as well at the age of 52. And what you can see here is a profound reduction in AHI at the 1 year in both group 1 and group 2, with many individuals going from that moderate to severe category to having mild or no OSA at the end of the trial. The average weight loss was around 17% for both study groups. And it's this SURMOUNT-OSA trial that's given tirzepatide secondary FDA approval for individuals with a BMI greater than or equal to 30 with moderate to severe OSA. And again, this expands coverage to individuals with Medicare. Semaglutide does not have these trials, so it will not get this ancillary approval for sleep apnea. So it's very specific to tirzepatide. And then the third indication of use that we have currently is for MASH. So we have the Essence trial that was published last year. It was a phase 3 trial of use of semaglutide in individuals with known F2 or F3 MASH and obesity. Exclusion criteria were people with poorly controlled diabetes. So diabetics were still enrolled, but if you had an A1C greater than or equal to 9.5, you were not allowed to enroll. If you had chronic liver disease or significant alcohol use or CKD, those were also exclusion criteria. This is an ongoing study, 240 weeks, but they published the analyses early because it was so profound. And the study was about half female with a BMI of around 34 to start. And what you can see here is that there is this resolution of steatohepatitis with no worsening of fibrosis in box A, as well as a reduction in fibrosis with no worsening of steatohepatitis in box B. And then in terms of the secondary endpoint, we also see this resolution of steatohepatitis and an improvement in fibrosis in individuals on semaglutide compared to placebo. And noting what the weight loss was, just to sort of ground us, 8.5% body weight loss. So these are not huge numbers, but they're huge impacts on health outcomes. The Essence trial has given semaglutide 2.4 milligrams FDA approval for use as of August in F2 or F3 MASH alone. There is no BMI criteria required for this FDA approval, but the study BMI average was 34, so most likely it will incorporate our patients who have obesity. This is a sort of no man's land right now. Oftentimes we get these FDA approvals and we don't exactly know how to get them covered. What we're hearing right now from the insurance companies in our local ecosphere is that we can have this MASH diagnosed proved by either biopsy or non-invasive testing like FIB4 elastography or MRI. The big caveat, which is a downer for us in generalists and even obesity medicine specialists, is that insurance companies are signaling they're going to require a hepatologist to somehow be involved in the care by attesting that they on how to operationalize that. But it's an important sort of disparity for our patients who are largely going to be seen in primary care for this issue. For tirzepatide, Synergy NASH is enrolling now and will finish up in 2027, so hope to have similar FDA approval in a couple years. So those are the 3 studies for comorbidities that we have these secondary FDA approvals. I'm going to unpack some more data, but it's important to note that while the next set of data is interesting and impressive, your patients can't get these drugs covered for the following comorbid conditions. So the first is HFpEF. We have semaglutide 2.4, 13.3% body weight loss at 1 year with an improvement in heart failure-related symptoms. This is currently in the FDA. We were hoping to hear back by the end of this year, but haven't yet, which is never promising, but it is in the FDA, so things could change. For tirzepatide in the SUMMIT trial, again, we saw this 7.2-point improvement in the Kansas City cardiomyopathy questionnaire, but this did not get FDA approval, and the pharmaceutical company is not indicating that they will resubmit with new data. So heart failure does not have this ancillary indication, but we do see improvements in symptoms for our patients with heart failure and obesity. The next is prediabetes, which seems pretty obvious. So for step 10, this was the use of semaglutide in individuals with obesity and prediabetes for 1 year, about 12.2% body weight loss. And this is looking at the odds of someone developing normoglycemia at the end of the trial. And we can see about an odds ratio of 20 for those on drug compared to placebo. With tirzepatide, they did a much longer study of about 3 years looking at the risk of converting to diabetes. So those who received tirzepatide compared to placebo were 93% less likely at the 3-year mark to convert to diabetes, which is pretty profound prevention. And for CKD, we have the step 1 through 3 exploratory results, which are actually not that great because almost everyone had normal kidney function, but we do see that there was not a change in eGFR, and we did have an improvement in albuminuria at that 1 year. But for tirzepatide, they are doing a prospective RCT in people with CKD in the TREASURE CKD study. This is enrolling through the beginning of next year and will include individuals with both obesity and CKD. For knee OA, I previewed step 9. This was a trial that looked at individuals with obesity as well as moderate pain and knee OA on imaging. They lost around 10.5% of their body weight at 1 year, and they had profound improvements in their function score as well as their WOMAC score. Tirzepatide is doing something similar with the STOP Knee OA trial, enrolling through 2027, so we'll get more data to come. And that's really just the beginning. These medications are being studied in all sorts of different conditions. Substance use disorder is probably the next most robust area we have. We know that in animal models, GLP backbone medications decrease both drug seeking, drug access, and drug use behavior, so sort of the 3 aspects of addiction. And they're starting to study these drugs in humans as well, and the lower doses seem to be more promising. We're also looking at these medications for methamphetamine use disorder, but in individuals who are cachectic, there are some interesting nuances proposed on how to dose these meds that could further decrease appetite. There's also been a lot of promising data for cognitive disorders, and there are prospective trials being done for things like dementia, Alzheimer's disease, and Parkinson's. We've seen profound improvements in our patients who have autoimmune disease, specifically psoriatic arthritis and RA. So these are being prospectively studied as well as for things like IBD and lung disease. And then studies are also being conducted for breast cancer, HS, and AFib. So while these medications are amazing and we want to do as much as we can to get these drugs into our patients' hands, it's important for us as providers to pause and think about, why are they not getting to patients? I think everyone's first sort of gut is going to be insurance, but it's important to note that we're part of the problem. There are significant disparities in terms of who actually receives prescriptions, which is the first entry point to receiving the medication. National examination of EPIC data for individuals with obesity in the absence of diabetes showed that in of 39 million eligible patients, only 2.3% received prescriptions. That's an incredibly small percentage of patients. Who was getting it though? Who is more likely to get prescriptions? Younger patients with higher BMIs in that class 2 obesity range, females more than males, non-Hispanic whites, patients who are less socially vulnerable, and those living in metropolitan areas were more likely to get prescriptions compared to those who didn't. And locally, we've unpacked this data as well. Our obesity medicine fellow, Dr. Alokika Shah, has been examining this data, looking at prescribing rates in an academic primary care setting at UCSF. About a third of our patients have obesity, and about 25% of those patients received prescriptions from 2021 to 2024. So we're doing much better prescribing these medications compared to national data, but we're still leaving behind a lot of patients. And who is that? People who have Medicaid are less likely to receive these drugs. And that does not make sense because Medicaid in the state of California has been very generous covering these medications for obesity. Medicare obviously excludes them, so that one makes more sense. Our patients who are non-English speaking or non-English proficient are also less likely to get these medications, as are our patients who are Asian or Black and African American. So while we think about how exciting these medications are, it's really important for us to look within to make sure that we're prescribing these medications in an equitable fashion. Okay, so I've spent the last 40 minutes convincing you all why you should prescribe these, and now you're going to think about the equity and how we can do this equally. But the big question is, what am I actually supposed to do? It's really hard to get these medications into our patients' hands. And I totally sympathize with you because insurance companies change their policies constantly, and they don't update providers when they're going to do it. They're incredibly opaque when they make these changes as well. So we're kind of throwing pasta at the wall and see what sticks and trying to build these algorithms based on all of the feedback we've gotten, which is quite hard if you don't have the staff to help you do this. It is easier to get coverage for these medications if there is a dual indication. So that is for Wegovy, the CVD with a BMI over 27, or MASH with F2 or F3. And for Zepbound, that's the moderate to severe OSA with obesity. And most almost always require a prior authorization that requires very specific things. One is a weight, height, and BMI from the last 30 days. So your patient who you haven't seen in 7 months that my charts you, unfortunately, they're going to need to come in to get those vitals. It actually makes sense in terms of clinical care. You would want that anyways, but you can really say the insurance is going to force your hand there. The other bit that is challenging is that they require this statement that a patient has been enrolled in an ILI program that includes diet, exercise, and behavioral change. And despite this work, patient has not lost weight or hasn't lost adequate weight. And most insurances actually require proof of this, either through your notes or the patient enrolling in an insurance-approved ILI. Now, what are we doing at UCSF? I'm sure some of you in the audience or those who are watching are thinking, Diana, I try and send my patients to you and your wait list is 6 months and it's just really not fair to patients. And so I'm happy to report that we have just received a PCORI implementation grant that's focusing on implementing intensive lifestyle change intervention for weight loss across all of primary care at UCSF. The team includes myself as well as Ralph Gonzalez as co-PI, doctors Gadgil, Garcia, and Satterfield who are implementation experts in DGIM, and this will be a population health approach. Pop Health will screen and enroll in this first implementation plan. It's a 3.5-year study, and what are we actually doing? We are developing a 12-week program that's based on the diabetes prevention program with a model of asynchronous education of pre-recorded videos made by obesity experts with the group visit model led by generalists. We will be offering this both virtually and in person. And in order to help reduce those disparities, we are going to offer it in multiple languages to serve our community better. Now, what's to come in 2026? There's like a womp, 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 if I had audio effects. Not great. So Medicaid in the state of California is going to stop covering GLP medications for obesity alone. They are hopefully going to provide exceptions to these secondary FDA approvals. In November, when we were all at Obesity Week, there was a lot of press from the federal government talking about lower prices, but where we are today is that pharmaceutical companies have dropped out-of-pocket prices if you're buying directly from them. The lowest price is $199 for the lowest 2 doses of semaglutide 2.4. But to get the tirzepatide and the higher doses, you could be approaching $350 a month. Our own ecosystem is also making some detrimental changes with UCOP limiting access to these medications for individuals with a BMI greater than or equal to 40. So that's leaving out everyone with class 1 and class 2 obesity, not to mention the fact that Asian and Asian American patients, including those from the Indian subcontinent, have known obesity at lower BMIs. We're hoping to have exceptions for people who have been on the medication already, but those details are still being ironed out. And we also are hoping for exceptions with these secondary FDA approvals. Maybe a little bit of a positive. So as of now, Medicare does not cover any medication for weight loss. This is by law. The Medicare Modernization Act of 2003 that labels these as vanity drugs. So think of all the bias there. And there's no way to get around this. Even the most expert ChatGPT generated prior auth can't get around a law written by Congress. The exceptions are, again, those secondary approvals. And the federal government did announce that in 2026, they will be making changes with a $50 copay being a potential option, but there are no details and nothing has been signed. So we can only act in the information we have right now, which is Medicare will not cover these drugs in the absence of these secondary indications. And what's on the horizon? In San Francisco, I like to call this the gold rush. So what we can expect in 2026 are some oral GLP-1 receptor agonists. Orforglipron is probably going to come a little bit sooner than the high-dose oral semaglutide. The key here is a little bit lower rates of weight loss than the injectable semaglutide and higher rates of discontinuation in the RCT of about 24% on Orfo, and it's unclear why. There was no obvious signal if it was directly related to an AE or not. But for comparison, the injectable overall discontinuation rate for these studies was around 8%, so much higher discontinuation at 1 year. And there are many other dual agonists that are being studied right now in phase 2 and phase 3, things like GLP and amylin, GLP glucagon, GLP and GIP antagonism. And then what we're really excited about is the triple receptor agonist retatrutide, which is a GLP, GIP, and glucagon receptor agonist. In phase 2 trials, it showed 24% body weight loss at 48 weeks. The phase 3 is enrolling through the end of this year, so hopefully we'll get more data next year. And then there's also medications that have nothing to do with the nutrient-stimulated hormone backbone, with the activin receptor inhibitors, things like bimagrumab, that are examining if there's any potential for muscle-building medications, initially studied in things like Duchenne's, but not effective in people who don't have baseline muscle function, but potentially beneficial in individuals with obesity. So just a quick summary here. There are many indications now for usage of these GLP medications in the FDA for treating obesity. We know that there's obesity, obesity CAD, OSA, or MASH. Maintenance is really key when we're trying to talk about being health promoting and helping our patients live longer, healthier lives. We need them to stay on their interventions to give them those results. There are many gaps in the literature, both in terms of who's going to respond, who's not, the disparities, and body composition. So if you're curious and see some students, if this is an area that's interesting to you, there's so much still to be done, and we're hoping to help fill those gaps here at UCSF. And the other thing is there's many, many more drugs to come. Many providers in the room have probably felt like they've heard about these from patients before they read about them themselves. And you're not wrong, because pharmaceutical companies are allowed to publish top-line data before anything hits a journal. So try and stay up to date as much as you can, but also make sure the literature is out there before you update and change your clinical practice to using these drugs. And with that, I'll leave time for questions.
That was really awesome. A lot of really practical pearls and a great overview with getting into a little bit more of the nitty gritty of prescribing. So thank you. I have a couple of questions myself, and then I'll throw it out to the audience, and had some great ones online as well, if we have time. It was really interesting how you were talking about all the other potential uses that people are considering, GLP-1s in. Autoimmune disease, is the mechanism related to the inflammation due to adipose tissue, or can you talk a little about that?
It's a little bit of both. So adipose tissue is pro-inflammatory, so decreasing that inflammatory cascade just from the adipose tissue itself. But there's also thoughts that GLPs can reduce the effects of certain interleukins, and that's why it's more effective with specific autoimmune diseases and not just sort of a panacea of autoimmune conditions.
In terms of patients who may have questions or concerns about, longer term use of these medications, because as you said, the benefits once you go off of them don't necessarily endure entirely. And so given kind of the more limited time frame that we have in terms of data, like how do you counsel people in terms of what you're concerned about and safety and all those sorts of things? What should primary care doctors be telling their patients when they ask?
The first GLP that hit the market came on board in 2003. So I think this idea that these medications are new is not correct. And even in terms of the obesity landscape, Saxenda came on board in 2013. So we've had patients on GLPs for 20 years. Now, we haven't had as many patients on them, so perhaps there will be new signaling data or more complex patients that we see things arise. But I think the idea that these are new it's not as accurate of a descriptor as people think. It's just new to the psyche of sort of society, but it's not new to the medical community.
Got it. Thank you. And then one other question just about, as an expert, like counselor, to people who are working for weight loss, this 150-minute recommendation, people may objectively know that they need that number, but how do you help work with your patients to help kind of operationalize that? Because it seems like the GLP agonist, one advantage is that it's like a very regimented thing that you do. It's a finite episode that you give yourself, and then exercising is sort of like a daily task potentially. And how do you just help people get there, I guess?
With all of the lifestyle modification work we do, it's really about motivational interviewing. And so that people part of being a doctor and why I love medicine is because you have to understand where someone is coming from and how to then move the needle in a way that they'll actually execute. And so understanding what someone has enjoyed doing in the past, what they have access to and how their body moves now is what you start with. And then you just progressively make changes. But it's important to, again, nothing is linear. And so patients get very discouraged when they're like, I've been walking and now I have plantar fasciitis, or I've been doing so great, but I'm traveling, whatever it might be. It's a reminder of this concept of upcycling. You are going to probably stagnate or even maybe go down. Even a marathon runner is doing that. But as long as you're continuing to focus on goals and moving the needle there, you will make sustainable long-term changes. So there's no prescription on telling what each person should do. In residency, I used to walk. Suresh was my attending. I would make my team go for walks for 5 minutes. Just finding these bursts of time when you can counts. It doesn't have to be all at once.
Great. So take the stairs if you can.
Take the stairs, yeah, if you can.
Some questions in the audience.
Oh, hi, I'm Audrey. I'm one of the chief residents here. Fantastic talk, really exciting. I was just messaging the residents about those really impressive hazard ratios for pre-diabetes trials. My question was more about any signal for like ophthalmologic disease, and especially like any counseling you might recommend. I think we had one patient that we were concerned was maybe GLP related vision issues, but was wondering how concerned we should be in counseling.
That data is in individuals with diabetes. So individuals who have diabetes have this increased risk of retinopathy and things like that. But in the patients with obesity alone, in the absence of diabetes, that has not been coming up. Yeah.
Thanks. Hi, I'm Alan Treadwell in primary care, and I've been prescribing these medications for a while, and what's interesting to me is that there is more of a, I don't want to say social stigma, or there's a lot of baggage around people using these, and even in patients who I think would really be helpful, I'm trying to get them over these hurdles. One of them is they feel like they don't want to be on something for the rest of their life. And you didn't really address any strategies for tapering patients off if they do want to come off these medications, or do you just say you're going to be on this, forever? Do you have any advice that we could use to help with that?
What I do is I'm very clear about the data up front. I know my patients quite well, so many of them are very honest. And so I would prefer to talk about it in the case where you have no choice, right? Like if someone is contemplating, I just don't want to take it anymore. I think with explaining the data, usually people understand the why. And if they're really, the patient-centric approach would be to come down the way you went up. So go down gradually at any sign of weight gain or increased hunger signal. That's their own litmus test that's probably not going to work to come off. And let's say someone does successfully come off, especially a younger patient or someone who doesn't have chronic obesity who might be able to successfully come off. The key is that they know the door is always open to come back at the first signs of weight regain. Not necessarily say you have to go right on the drug again, but to really make sure those lifestyle change interventions are really robust. The more unfortunate situation is the patient that has to stop because of insurance changes, and because that's oftentimes very abrupt. We tried to have this preemptive approach with what was happening with Medicaid, but they're still telling us what's going to happen now. We don't know. So in those cases, we're transitioning patients to other medications. But if your patient wants to come off, I sort of think about it like depression. Let's make sure you're stable at your plateaued weight for 6 months. So it's probably 2.5 years on drug. And then let's talk. Let's see what's happening in your life and your ecosystem at that time. If it's a really stressful time or a huge change for you, it's probably not the right time to try and come off the medication.
So, Diana, great talk. Sunil Koliwad from endocrinology. Now that we have amylin, multimolecular, specific unimolecular, and a host of new targets that are affecting different brain regions that are coming out and will be FDA approved in the next couple of years. Mm-hmm. What's your wish list as a large-scale provider who takes care of patients with these medicines that you'd like to see these drugs do in the future? Is it more about side effect mitigation? Is it more about plateau? Is it more about ancillary indications? What is the thing that you really feel like you'd want to see these drugs tackle that currently we're still in development for?
That's a great question, Sunil. I think that the side effect profile is probably the biggest one, because someone who's not tolerating upper GI side effects with semaglutide may do better with tirzepatide. In the obesity literature, there are fewer GI side effects. That's not always the case. And so if we can get a medication that's targeting another hormone so that it's not so much of that constriction of the gastric outlet, decreasing some of those GI side effects, I think that's important. I think the other thing is a more precise approach to the menu. So how can we triage a patient and their risk with their current adiposity and their comorbidities? And is there more nuanced data in these ancillary indications to say someone with a class 3 BMI and X, Y, and Z should be on this drug, whereas someone with class 1 obesity and PCOS should be on this medication? I think there's so much still to come there, but just having a menu of options, and then also additive approaches. So let's say someone has some weight loss, but not enough to start seeing these meaningful changes in comorbidities. How can we add other medications without too much of agonizing one receptor to still promote more weight loss and improve their outcomes? I don't think the injectable is a problem. I think people always anchor on, well, don't you want orals? I don't think orals are as good in terms of efficacy, and I think they have more side effects, and people don't mind the injectables. So I don't think sort of delivery is that key to me for my future paradigm.
Great. One more question.
Hi, I'm Jordan Chen, postdoc from Baker Institute. So my question is, how much of the effects, especially regarding the secondary indication, for example, like cardiovascular outcomes or like fibrosis, prevention of fibrosis, can be explained by weight loss alone, as compared to like the real effect of the drug, like as a whole? Thanks so much.
That's a really important question. So the cardiovascular effects are not fully driven by weight loss. I think when you look at it being 8.9% and how quickly you started to see that curve, even preceding large amounts of weight loss, the drug itself has these anti-inflammatory effects that are impacting the cardiovascular outcomes. I don't know. Do we know, Sunil, the data on that? We don't.
The newest study just a month ago, the SOUL trial with oral semaglutide, showed a complete dissociation in some of the figures between relevant MACE and related cardiovascular endpoints and any significant weight loss being required for those endpoints.
Yeah, but we don't know sort of how to allocate each of those responses. For mechanical diseases like OSA, it's largely the weight loss. And for MASH, assuming as well, reducing the fat content in the liver is helpful, but so is that anti-inflammatory effect. So I think for some of the other conditions, there's both, but in terms of the cardiovascular and also with the autoimmune disease data that hopefully we'll get in the future, I think a lot of that is driven by that impact on the interleukins.
And interestingly, the EVOKE study for cognition notably studied non-obese patients from the get-go. Any ancillary data that they get from that will be devoid of any obesity that was present in the patients.
Yeah, and they're actually doing an RCT in lung disease for individuals with normal weight for tirzepatide. So again, it'll be completely in the absence of adiposity.
Thank you. We're at time, but happy to take questions up here. Thank you. See you next week.